Good afternoon. So over the next few minutes, we'll be talking about imaging of endometriosis. This is an outline to my presentation. So according to the current WHO classification of gynecological tumors and related pathologic conditions, endometriosis is defined as the presence of endometrial glands surrounded by endometrial stroma in anatomic locations beyond the endometrium. It is a chronic, debilitating gynecological disorder affecting women of reproductive age group, accounting for about 6 to 10% of general female population, and about 25 to 50% of infertile women have endometriosis, and about 30 to 50% of women with endometriosis are infertile. About 20 to 25% of patients are asymptomatic, and the ectopic endometrium, it responds to hormonal stimulation with various degree of cyclical hemorrhage, causing symptoms depending upon the structures involved, commonly being dysmenorrhea, chronic pelvic pain, dyspareunia, and infertility. Among the various theories of endometriosis, the most widely accepted is the theory of retrograde menstruation. The other theories being lymphatic and vascular spread, which is a basis for the extrapelvic endometriosis, iatrogenic implantation, basis for scar endometriosis. There might be metaplasia of the coelomic epithelium, and also the shed endometrium may release substances which induces the undifferentiated mesenchyme to form endometriotic tissue. Anatomically, endometriosis can be divided into pelvic and extrapelvic. The pelvic location can further be divided into anterior compartment, which consists of the urinary bladder, urethra, the uterovesical fold, the middle compartment, which involves the uterus, vagina, fallopian tube, ovaries, the broad ligament, proximal portion of the round ligament, the posterior compartment, which includes the pouch of Douglas, the rectovaginal septum, and rectum. And in the extrapelvic location, probably spleen is the only organ where the endometriosis have not been reported. Phenotypically, endometriosis can be either ovarian endometrioma, superficial endometriosis, and deep endometriosis. This may occur isolated or in combination. Earlier, deep endometriosis was defined when the endometriotic tissue infiltrated the endometrium more than 5 mm, but in 2021, it has been redefined as any degree of infiltration beneath the peritoneal surface. These are beautiful laparoscopic images which were shared by my gynae colleagues showing bilateral endometriomas, the kissing ovary, the right hematosalpinx, the left hydrosalpinx, the chocolate cyst, the laparotomy image showing the endometrioma, the deposits in pouch of Douglas, the superficial deposits, the powder burn deposits, the filmy adhesions, as well as the dense adhesion. Traditionally, laparoscopy was the gold standard for diagnosis of endometriosis, but the recent national and international guidelines have shifted their focus to non-invasive image-based diagnosis. The ESHRE Guidelines 2022 has stated that laparoscopy is no longer the diagnostic gold standard and is now only recommended in patients with negative imaging results and/or where empirical treatment was unsuccessful or inappropriate. So we have two imaging modalities, the transvaginal sonography and MR. Beginning with transvaginal sonography, it can be either routine pelvic ultrasound or augmented pelvic ultrasound. Routine pelvic ultrasound is the ultrasound that we routinely perform as the TVS for all the conditions pertaining to uterus, ovary, adnexa, and pelvis, whereas when there is clinical suspicion of endometriosis, there are certain maneuvers which are added to the routine pelvic ultrasound, which is the augmented pelvic ultrasound, of which we'll be discussing further. The SRU consensus have given the consensus for screening the patients for this endometriosis, and the IDEA consensus have given these 4 steps to conduct the transvaginal sonography, the augmented pelvic ultrasound. The first step being the routine evaluation of uterus and adnexa to look for adenomyosis, presence or absence of endometrioma. Second step is to look for the soft markers, that is the site-specific tenderness and ovarian mobility. Third step is to look for the sliding sign. And the fourth step is to look for the deep endometriosis nodules in anterior and posterior compartment. The ISUOG has given a simplified protocol in which they include only 3 steps. The first step is to assess the uterus and ovaries. Second step is to look for the sliding sign. And third step is to look at the posterior compartment, since this is the most common site of deep endometriotic nodules. In first step, we are looking for the uterus, the fixed retroflexed uterus giving the question mark appearance, the various direct and indirect features of adenomyosis as given by the morphologic uterine sonographic assessment, the MUSA criteria. These are the typical endometriomas, the unilocular or few locular cysts with homogeneous low-level internal echoes giving the typical ground glass appearance, or this might be bilaterally and it might abut each other behind the uterus, giving the kissing ovaries. These endometriomas may also have these nodules, hyperechoic nodules at the edges, and sometimes may also have this dependent layering-like appearance. But what is atypical is to have these solid nodules, the papillary projections. If it is there and if there is vascularity in these nodules, either other malignant ovarian neoplasm, malignant transformation of endometrioma, or decidualized endometrioma should be suspected. In second step, we are looking for the ovarian mobility. So here, we first locate the ovary, then with the transducer we apply gentle pressure and the ovaries should be sliding smoothly. We can even apply intra-abdominal pressure over the lower abdomen and see the free mobility of ovary. The third step is to look for the sliding sign, and this differs if we are performing it in an anteverted uterus or a retroverted uterus. This is the normal sliding sign in the anteverted uterus. We can see that as we apply gentle pressure with the probe, when the probe is placed in the posterior fornix, it will glide smoothly. The cervix and the posterior vagina will glide freely across the rectum, and this is the operator will place another hand over the lower abdomen of the lady and will ballot the uterus, and then we will see these movement. If I could play this again, sorry. And this is in case of retroverted uterus. In retroverted uterus, this is the smooth sliding that we can see of the uterine fundus with the rectal wall. And here is also the free gliding of the anterior-inferior part of the uterus with the bowel. This was a 36-year-old female. This is the longitudinal sweep, which shows the normal anteverted uterus, but she has bilateral endometrioma, the kissing ovaries, and we performed sliding sign. So here we can see how the movement is restricted. It's basically a frozen pelvis. And this is this is the same case. After we applied the intra-abdominal pressure trying to ballot the uterus, there is restricted motion. So this is also frozen. The fourth step, we are looking for the endometriotic nodules. We look for the posterior and the anterior compartment. So fluid is our friend. So whenever there is fluid in the pouch of Douglas, it helps us to assess the posterior compartment well. We are looking for the hypoechoic nodules in the posterior compartment. We look at the retrocervical region. We look for the uterosacral ligament. The normal uterosacral ligament is smoothly echogenic. And usually it's not visible on ultrasound. But if there is endometriosis, we will see this irregular thickening and hypoechoic nodules. These are endometriotic nodules in the anterior cul-de-sac. And these are the endometriotic nodules which are infiltrating into the rectal wall, into the muscularis, which might be unifocal or multifocal. So depending upon these findings, we can categorize our findings into direct endometriosis observation, indirect endometriosis observation, which is due to the fibrosis, and the endometriosis associated observation. And we can report it into these categories. The category 0 being the incomplete study, when we are unable to perform the exam due to the technical or patient factor. There is 1, if there is no imaging appearance of endometriosis, if there are no direct or indirect observation. Equivocal, if there is only one category 1B observation. And positive for endometriosis, if there is any category A observation, 2 category B observation, 1 category B and 1 category C observation. So, so far we talked about deep endometriosis, but recently there is focus towards this superficial endometriosis, which has been extensively studied with ultrasound. And for those of you interested, I would like to refer you to this article where they have shown that even the superficial endometriosis can be seen very beautifully on ultrasonography. We might have to perform some additional techniques such as the sonopodography. So now moving on to MR. The European Society of Urogynecological Urogenital Radiology has said that MR is recommended as second-line imaging technique in the preoperative workup of deep infiltrating endometriosis. MR may be used for diagnosis, but it is commonly used for surgical planning for preoperative mapping of the disease extent. In the MR protocol, there is no recommendation for timing of MR in relation to the menstrual cycle. The use of vaginal and rectal opacification is optional. And in the sequences, what we should not be missing is the T1 weighted images without and with fat suppression, and also to screen the upper abdomen. So here we have these 2 comparative images. The second image, there has not been well opacification of the vagina and the rectum. And in the first image, we can see the opacification of the vagina and the rectum, showing the endometriotic nodule affecting the vaginal fornix. In MR, the endometriomas will appear as the T1 hyperintense multiplicity. When there are multiple T1 hyperintense cysts in the adnexa, endometriosis should be suspected. And there will be this typical T2 shading effect, in which it will appear homogeneously high in the T1 weighted image without the loss of signal in the fat saturated images, and there will be loss of signal in the T2 weighted image, which is due to the high concentration of iron and protein. Due to the retractile clot, there might be dark T2 spot sign. The superficial endometriosis is difficult to identify on MR unless they are hemorrhagic or hyperintense on T1 weighted image, and deep endometriosis will appear as hypointense nodular lesions or soft tissue thickening with irregular, indistinct or stellate margins on both T1 and T2 weighted image, and there will be architectural distortion. As we can see, the batwing configuration, the ill-defined T2 low signal intensity area infiltrating the retrocervical region, infiltrating into the rectal wall and into the parametrium. And here we can also see the thickening of bilateral round ligament. And here there is the batwing configuration, which has infiltrated into the ureter, causing ureteric compression. And this is the typical fan-shaped or mushroom cap configuration seen with the rectal involvement of endometriosis. This is the anterior cul-de-sac endometriosis. And there might be this thick fibrotic band, which will cause there will be adhesion of different organs together, giving the appearance of clover leaf configuration. These are some extrapelvic endometriosis, the scar endometriosis, the laparoscopic images, inguinal, diaphragmatic, a few more minutes, and diaphragmatic endometriosis as well as sciatic nerve endometriosis. I would just run through the rest of the slides. These are the ASRM classification of endometriosis, which is used by our gynecologist. And with MR, we have about more than 20 different classifications. Some of the classification being the Endovalrim group classification, where they have compartmentalized the affection. And we have the Enzian classification, which can be used for ultrasound, MR, as well as surgery. There is this endostage classification, where they have also given the risk stratification for the surgery. Just few pearls, if there are multiple hyperintense T1 hyperintense adnexal cysts, it suggests endometriosis. Obtaining fat-suppressed image is a must, since even the dermoid may have T1 high signal intensity, so we have to differentiate it from there. And if there is bilateral hematosalpinx, it also suggests endometriosis. Endometriosis may restrict diffusion. Focal segmental adenomyosis is basically endometriosis, that is the outside in process. So while reporting endometriosis, we have to include these points. We have to compartmentalize our lesions. And to summarize, endometriosis is a chronic heterogeneous gynecological condition with multi-organ involvement. And we discussed about the transvaginal sonography being the initial imaging modality. We talked about the IDEA and the SRU consensus and the role of MR in disease mapping. These are the references to my presentation. Thank you.
Thank you.